Pleasure.
I know.
So good to see you again.
Yeah, good to see you. Thank you so much. I believe I can start my introduction. I think we're live. So welcome everybody. I'm Mary Heary, the APRN here at the Smilow Family Breast Health Center at Newark Hospital, a part of New Vance Health East. We're so fortunate to have Dr. Shari Goldfarb, an expert on sexual health, speak to us tonight. She will present on sexuality following the diagnosis of breast cancer. Sexuality is always an interesting topic at any time, but it's an especially important topic for patients who've been through treatment for breast cancer. Dr. Goldfarb completed her bachelor's degree in nutritional sciences from Cornell University and her medical degree from Upstate Medical University in Syracuse. She did her residency at New York University Hospital and her fellowship at Memorial Sloan Kettering Cancer Center. She holds a dual appointment at Memorial Sloan Kettering in the breast service and in the health outcomes department in epidemiology, where her expertise is improving the quality of life in patients with breast cancer. She's also the co-director of the Young Women with Breast Cancer program at Memorial Sloan Kettering, which is really exciting and so needed. She's also been the primary investigator on several research studies. A recent study has explored the use of Phlebanism which is a medication to help the sexual function following breast cancer treatment. And we eagerly await those results because we were fortunate enough to participate in that study here at Newark Hospital. She's on the board of several international organizations that focus on sexual health, and thank goodness she is, because it's a topic that certainly needs so many, a voice for so many women and men with sexual dysfunction following breast cancer treatments. She has spoken to both medical and lay audiences internationally, and it is our good fortune to have Dr. Goldfarb join us, where she will share valuable information on sexual health. Shari, good evening and welcome.
Thank you, and thank you all for joining tonight. So I'm going to talk to you a little bit about sexual health in survivors of breast cancer and breast cancer patients. And if you have any questions, please put it in the Q&A, and we can address them at the end of this talk. So here are my disclosures. So as more cancer patients are cured of their disease, and thank goodness each year we're curing more and more women, increased attention is being paid to quality of life and symptoms, both in the short term during treatment and in the long term throughout survivorship. We all know that sexual dysfunction is an adverse consequence of cancer treatment, and we sometimes forget that it affects both pre- and postmenopausal women. So we need to further study ways to treat this, and the efficacy and safety of currently available treatments is understudied. And it's part of what I do to try to study these treatments and to get more treatments approved for breast cancer patients. And it's especially important because menopause in the cancer patient, and especially breast cancer patients, is different. Often, our patients, especially our young ones, undergo abrupt or premature hormonal deprivation, which leads to greater intensity and duration of symptoms and negatively impacts quality of life. And since the majority of our patients are cured of their disease, quality of life is very important for our breast cancer patients. And what we try to do is enhance quality of life by coming up with treatments for the menopausal symptoms. And this is just to show you and remind you that sexual activity is important throughout the life course. And if you look here, the black lines is the number of partnered women. The gray lines is sexually active women. And the blue lines is women with GYN cancers, and the yellow lines women with breast cancer. So if you look at the young in the teenage years and the 20 years, the gray bars, more people are sexually active than partnered, which makes sense. But as you go into the 60s, 70s, and 80s, it seems like you're more likely to be sexually active if you are partnered. But women with breast cancer and GYN cancer, in the yellow and blue bars, continue to continue to have sexual activity throughout their life course, throughout their 60s, 70s, and 80s. And as more and more women are diagnosed in later years, it's going to be important because you want to keep these women sexually active if they want to be. And especially important we see for partnered women. We know that sexual problems are common after breast cancer, and there have been multiple papers, including some that I've written on my own, to show this. And we know at Sloan Kettering, when we did a study, 3/4 of our women reported some sort of sexual dysfunction, either during or after their breast cancer treatment. We see that it ranges in the studies from 30 to 100% of women surveyed. Many people report decreased desire and decreased libido, which is a common side effect of meds such as tamoxifen. Women have vaginal dryness, arousal and lubrication problems, difficulty climaxing and orgasming, and body image concerns. Many of the studies show that more than 50% of women who undergo breast surgery have some sort of body image concern, and greater than 90% of women report poor nipple sensation even after lumpectomies. From the patient perspective, when we surveyed them and asked them what factors contribute to worse sexual function, we found that 85% reported chemotherapy made them exhausted, fatigued, changed their relationship with their partner, and really interfered with their sexual function. 82% reported anxiety. 81% reported a new diagnosis, and with the new diagnosis came how their friends and family and colleagues looked at them differently, and their partners. 74% reported endocrine therapy or hormonal modulating therapy. 66% reported decreased sensation from surgery, and 55% said, we had a change in relationship. I'm now sick and my partner is the caretaker, and that's really impacted our sexual function and our intimacy. We know that endocrine therapy impacts sexual function, and both tamoxifen, aromatase inhibitors, and fulvestrant all adversely can impact sexual function. Aromatase inhibitors seem to be the biggest culprit of causing vaginal dryness, vaginal atrophy, vulvar changes, pain with intercourse. And tamoxifen, fulvestrant, and aromatase inhibitors all can cause equivalent hot flashes, decreased libido. And tamoxifen can cause more vaginal and endometrial sort of bleeding and discharge than others. But we know aromatase inhibitors that we're now using in more and more patients really cause a lot of our sexual dysfunction and vaginal dryness. And when looking back, even in a meta-analysis performed in 2007, we see that there's a benefit of suppressing young women's ovaries. Across the board, women tend to do better and have better breast cancer outcomes when they make less estrogen. And this contributes to us using more aromatase inhibitors and ovarian suppression, and leads to worsening sexual dysfunction and menopausal symptoms. For example, in the soft and text trials, when you look at the women that are younger than 35, there were 233 women. 94% of them had received chemotherapy, which is what you would expect with the youngest of our breast cancer patients. And it was quite a big difference in the rate of breast cancer freedom from breast cancer or disease-free survival in women who were younger than 35, whether they used ovarian suppression plus exemestane, which is sort of the most aggressive regimen, but also the one that's going to cause the worst sexual function. 83.4% of those were disease-free, though, versus if you did tamoxifen alone and didn't have as many sexual symptoms, but only 67.7% of these women were disease-free. So it shows that we really need to use these more aggressive therapies to improve the survival and outcomes of our patients, especially our youngest ones. And therefore, we have to get better at treating the sexual dysfunction. And ASCO, after the soft and text trial were published, came out with a practice guideline that said higher risk patients should receive ovarian suppression in addition to adjuvant endocrine therapy, whereas lower risk patients should not. So again, it's not everyone. Our patients with our small tumors that are less than a centimeter may do very well with no negative disease on tamoxifen, but our higher risk patients and our youngest patients probably should have ovarian suppression and estrogen lowering drugs, and these things will lead to worsening sexual dysfunction. And as you see here, when we look at vaginal dryness, it is more than half of the women on the soft and text trial who had ovarian suppression plus exemestane, which is an aromatase inhibitor, reported vaginal dryness. And 21% 5.8% reported it with tamoxifen. So it got progressively worse from tamoxifen, to tamoxifen with ovarian suppression, to exemestane plus ovarian suppression. And the same thing with the hot flashes. It was much worse when we suppressed people's estrogen. Decreased libido was also worse in young women who had ovarian suppression plus an aromatase inhibitor. And a third of the patients on the study pretty much reported pain with intercourse. And these are often unaddressed symptoms that we have to do a better job at talking to our patients about. Because changes in sexual health cause distress for patients. And when we don't bring this up and discuss it, patients don't always know why they're feeling this way. And when distress is high, sexual desire is low. And a decreased libido for someone who previously did not have one could cause confusion, embarrassment, change in their relationship with their partner. And many people are not cognizant that their sexual problems are related to their treatment. And often don't want to bring these discussions up with their physicians or their clinicians, but they want to talk about it. So in general, healthcare providers should initiate these discussions, and patients should, also try to bring them up if you can, because it's important, and all patients should know that these sexual problems are related to your treatment. It's things that we are causing. So how can we help our patients, and how can patients help themselves? So American College of Obstetrics and Gynecologists came out with an opinion that said non-hormonal approaches are the first-line choice for managing urogenital symptoms or atrophy-related urinary symptoms experienced by women during or after treatment for breast cancer. So we always want to do what's safest. We worry in women with estrogen receptor positive cancers that giving estrogen can negate what we're doing. So we always want to try safe non-hormonal options first. However, there are, and I'm going to show you some data, some patients do require more than non-hormonal options, and then a decision to use vaginal estrogen or vaginal DHEA or vaginal testosterone should be preceded by an informed decision-making and consent process with a clinician and the patient, in which women can make their own informed decisions and weigh the risks and benefits. I have patients in my practice with metastatic breast cancer who intimacy is so important to, and they're on low dose vaginal estrogen because they don't want vaginal dryness, and they want to continue their relationship with their partners, and I think that's really appropriate. And I also have patients who may have tiny, small tumors who have vaginal dryness but don't want to treat it because they're worried about fear of recurrence. So it's really a discussion with a clinician and a patient to do what's best. There are many safe management strategies for sexual dysfunction in breast cancer patients. I'm going to go through a few. Often randomized clinical trial data in outpatients is lacking, but I'm going to show you some data and some randomized controlled trials that I have. But we know lubricants and moisturizers really make a difference. Understanding the differences between lubricants and moisturizers and when each should be used is really important, and I'm going to review that because that is something really easy for patients to just start on their own and to discuss with their clinicians, and it's really easy for clinicians to spend a minute discussing with patients in clinic also. Counseling, sex therapy, altering medications like SSRIs that may be contributing to decreased libido and difficulty with arousal, physical therapy for pelvic floor disorders, mechanical devices, dilators, vibrators, sexual positioning aids, topical lidocaine, and then we'll discuss in detail sort of the local intravaginal hormones. So lubricants. There are many different kinds of lubricants. Often the lubricants people know are water-based lubricants, and they have a short duration of action and should be used and applied frequently, but just used as needed and really used prior to intercourse or penetration. They help to improve dryness, decrease pain with intercourse, and minimize friction and irritation. They're safe to use with condoms. These are things like KY Jelly, Astroglide, Liquid Silk, Good Clean Love, Pre-Seed, and they're very short acting. So this is on an as needed basis. There are also silicone-based lubricants. These are longer lasting than water-based lubricants. They're a little bit messier, but they're often better for someone who's having significant vaginal dryness. They're safe to use with condoms, but they shouldn't be used with silicone toys. Again, they're used as needed, and this is something like KY Intrigue or Uberlube or Pink. And petroleum-based lubricants are the longest lasting, but they're not safe to use with condoms or diaphragms and can be more irritating. I have a lot of patients tell me that when they try to use these, they're itchy or that they have a rash, so I usually don't recommend it. And lubricants are different than moisturizers. Lubricants are used as needed prior to penetration. And vaginal moisturizers should be used all the time, whether or not someone's sexually active, whether or not someone is planning to be sexually active. Vaginal moisturizers just help to keep the vulvovaginal tissue healthy. They hydrate the tissue. They help to keep the tissue more elastic and decrease irritation. When people get a lot of vaginal dryness and atrophy, you can get UTIs. You can have pain with GYN exams. You can have pain with intercourse, pain with any type of penetration. Vaginal moisturizers are for you. They're to help you keep your tissue healthy. They're much longer lasting than lubricants. Common ones are Replens, which some people say is a little goopy, or some of the hyaluronic acid-based ones, like Hyaluronic, which is a hyaluronic acid-based kind of gel. My patients really like it. They say it's not as goopy and it's quite effective. Hyalufem is another product like that, or Reverie, which is a hyaluronic acid suppository. Hyaluronic acid is used in fillers. It helps with facial filling, but it also helps with vaginal hydration. Vitamin E capsules. There are many different moisturizers, and usually it's recommended on the package to use every 2 to 3 days. And this just helps to replace vaginal secretions and to help keep your tissue healthy. But what we have found is that in our population, that's usually not enough. And really, if you use it more frequently, 5 times a week, often 4 or 5 times a week, it really, you see more benefit and helps to keep the tissue healthy. And it can take, if you're really dry, up to 2 months even to start seeing full benefit. But if you continue at it and use it consistently, we really do see good results and even objective results like change in pH when we've done studies. And I'm going to show you some data in a second. And it's a really safe alternative to intravaginal hormonal therapy and something that I really push my patients to try first before I start prescribing intravaginal estrogens or testosterone or DHEA. And the nice thing is there's lots of variety and you could try different moisturizers. I also recommend when you're using vaginal moisturizers not to use it just intravaginally, but to put some on your finger and use some externally to help keep the vulva healthy. And here's just a list of some commonly used moisturizers. They're often not cheap, but sometimes I know Hyalufem and Hyaluronic give coupons to cancer patients. We'll give free samples. We'll give you, if you go on the website, if you go on the Hyaluronic website, you can get a free month. So there's different things you can do. And sometimes, we're working on getting insurance to cover these, but right now they're not covering most of these. But your health, if you have money put aside for a health fund, that would cover this. Dilator therapy is often very important for outpatients. It's also really important for endometrial cancer patients or any patients that have had intravaginal radiation. But when you're on an aromatase inhibitor for a long time or you're abruptly made menopausal, you often get vaginal atrophy, you can get stenosis. So using dilator therapy will help to mechanically stretch vaginal tissue. Using moisturizers prior to it and putting lubricants on the dilator is important because you want the tissue to be elastic so you don't bleed or have pain as you're stretching. But when you're using the dilators, you want to mechanically stretch the vaginal tissue to prepare you before penetration. This will help to treat stenosis, help to treat pain with intercourse, and also will just improve anxiety. A lot of women, if you've had pain with intercourse, are nervous to have intercourse again. So this gives you control, gives you the ability to stretch your own vaginal tissue, and then lets you, after you've had a chance to sort of stretch your own vaginal tissue, to re-attempt penetration or intercourse. Now, pelvic floor exercises are also really important. They help to stretch and relax pelvic floor muscles and sort of bring blood to the area. It will improve control and strength of the pelvic muscles, helps to decrease pain with intercourse and exams. And if you do pelvic floor exercises, see, we have great pelvic floor physical therapists. And if you see them for a few times, they can often give you exercises you can do at home. And you could do that at home and then use your dilator for a few minutes at home. And that generally is really helpful. The other thing, sometimes people find that they don't like using dilators, that they feel it's so artificial. So using a vibrator can often do the same thing. Now, as I was mentioning, we did a hyaluronic acid moisturizer study. The product that we used for this study was actually Hyaluronic. And in the study, we enrolled 58 women, breast cancer patients on aromatase inhibitors, and 43 women that had endometrial cancer who had intravaginal radiation. All the women in the study reported vaginal dryness or vaginal atrophy. And what we did was we administered intravaginal and external hyaluronic acid. And patients were doing it 3 times a week for 12 weeks. And then we assessed them. And people who responded continued on for 22 to 24 weeks at 3 times per week. But the non-responders were then increased to 5 times per week. And this is how we know that there's a large percentage of women who do require the non-hormonal moisturizers more frequently. So if you had no improvement in vaginal symptoms or vaginal pH or vulvar symptoms, and were still reporting atrophy and dryness and irritation, your hyaluronic acid was increased to 5 times per week until you reached week 24. And patients were monitored with clinical GYN exams and 2 vaginal scales, the Vaginal Assessment Scale and the Vulvar Assessment Scale, which are patient-reported outcome measures. And then patients also completed Female Sexual Function Index, Menopausal Symptom Checklist, which are patient-reported outcome measures. And objectively, we measured, pH, irritation, and exam things when we did the clinical exam. So what we saw from the VAS, which is the Vaginal Assessment Scale, is that there was a statistically significant improvement from baseline to week 12, and then a continued improvement from week 12 to week 24. But I will say that 3/4 of the patients at week 12 required an increase in their hyaluronic acid to 5 times weekly, 5 times per week. So we know that these measures can improve vaginal health and vulvar health, because we also saw a statistically significant improvement in our vulvar assessment over the time points. But we know that it requires really people using hyaluronic acid products or a moisturizer internally and externally 5 times weekly. And this just shows, the estimated symptoms and how they really did improve significantly in the first 4 to 6 weeks, and then on a slower rate, they continued to improve for the 24 weeks of the study. There was also an improvement in patient-reported outcomes. So the Female Sexual Function Index is a 19-question sexual health questionnaire, and we showed that the vast majority of patients at baseline had significant sexual dysfunction that improved along with the vaginal symptoms at the mid-time point, weeks 12 to 14, and then at the final endpoint, 22 to 24. And again, the trajectory improved quite quickly to week 12 and then a slower form to week 24. So we know that hyaluronic acid-based moisturizers, so this is like Hyalofem, Hyalogin, Reverie, that can improve vulvovaginal symptoms and tissue quality, because we were doing exams, we were measuring tissue quality, we were measuring pH. We know that there's improvement in vulvovaginal health, which positively impacts sexual function. But we also know doing this 2 to 3 times a week is not enough for cancer survivors. We need to apply moisturizers internally and externally closer to 5 times a week for most people in order to get symptom relief. Well, 2 to 3 times is recommended for healthy postmenopausal women. And we also know that despite increasing it to 5 times per week, there was still about 20% of patients who did not respond adequately to it and were still having symptoms despite using 5 times a week non-hormonal moisturizer. And these are the patients that we really start looking at hormonal drugs for. So I like patients to try, at least a 3-month trial of non-hormonal moisturizers 5 times a week before we move on to hormone therapy. But the FDA has approved for moderate to severe dyspareunia, pain with intercourse, several medications, and they look at it as pain with intercourse is a symptom of the vulvovaginal atrophy, which for our patients and is really caused by the medications we're giving. So Intrarosa is an intravaginal DHEA medication. It's the first local non-estrogen product that's been FDA approved, and it has no black box warning for cancer patients. And I'm going to talk to you about that in a few minutes, whether that they should have a black box warning or not, but that's one of the things. Pemifene is a selective estrogen receptor modulator, so it's sort of in the same class of drugs as tamoxifen. It's an oral non-estrogen oral tablet. It hasn't been studied in cancer patients yet, but most SERMs do decrease risk of breast cancer. It can't be given in combination with a SERM like tamoxifen because it can increase risk of blood clots, but it can be given in breast cancer survivors who've completed potentially all of their therapy. And then there's a new drug, which is really estradiol vaginal inserts, that's known as Imvexxy, that comes in 3 different doses. 4 micrograms, 10 micrograms, and 25 micrograms. And the Imvexxy 4 microgram tablet is really the smallest intravaginal estrogen that we have, FDA approved. We also have estradiol rings, estradiol creams, conjugated creams, and approved for atrophic vaginitis due to menopause is 17 beta estradiol tablets, which is like Vagifem, which has a 10 and 25 microgram dose. So here's a list of sort of the FDA approved intravaginal estrogens and their annual systemic absorption. So the 3 that have the lowest absorption are really the Imvexxy 4 microgram dose, this was from a paper in 2011 before Imvexxy was out, but I'm going to show you in the upcoming slides how Imvexxy even has less estradiol absorption or systemic absorption than Vagifem, which has an annual systemic absorption of 1.14 milligrams, which is actually quite low. And the estradiol ring is the next lowest, which has 2.74 milligrams. So if you're going to give a breast cancer patient intravaginal estrogen, it's safer to do it when they're on tamoxifen because you're blocking the estrogen receptors, but you want to still use a product that has low systemic absorption, such as Imvexxy 4 micrograms or Vagifem 10 micrograms or 7.5 microgram estradiol ring. Estradiol creams tend to have a lot more systemic estrogen absorption, and using them topically and externally, we know there's significant absorption when people are atrophied, so you're better off using a non-hormonal topically and on the vulva. So initially, when Vagifem first came out at the 25 microgram dose, Kendall et al. Did a study and they looked at 7 cancer patients that were on aromatase inhibitors, and they followed them. And they saw at week 2 there was some systemic absorption of estrogen, but by week 4 most of the patients had come down. But then they saw these spikes at week 7, and they said, "Oh no, patients are having systemic absorption," and they just stopped them and didn't further evaluate it. This was not done in a clinical trial. This was just done sort of retrospectively, and basically this caused fear. And intravaginal estrogen prior to this was being used in cancer patients, and this could have sort of stopped the usage. And it's kind of upsetting because it was really difficult to reach definitive conclusions on 7 patients where the treatment was stopped. And it just underscored the need for more rigorous clinical trials, and sort of stimulated this whole topic that's been researched. So there was a randomized controlled trial looking at vaginal testosterone cream versus the estradiol vaginal ring for vaginal dryness and decreased libido in women receiving aromatase inhibitors for early stage breast cancer. In this study, 76 women were consented to the study, 40 were randomized to the vaginal ring, and 36 randomized to intravaginal testosterone. 5 people were excluded in the vaginal ring arm and 2 in the intravaginal testosterone group. And what they found, and this is why the results are a little bit difficult to interpret, at baseline, the estradiol level was above the postmenopausal range in 28 out of 76 women. So 37% of the women at baseline had elevated estradiol. So it's hard to monitor the rise in estradiol when patients are starting at baseline with elevations. And it's unclear exactly why these elevations were there. And when I spoke to the PI on the study, she basically said we were in California and a lot of people were taking over-the-counter sort of herbals and supplements to treat their vaginal health and their menopause, which contributed to this. But it just makes it a little difficult to interpret these results. But it did show persistent, that there were no persistent estradiol elevations observed in patients with the vaginal ring, and elevations in estradiol were seen in 4 out of 34 women with intravaginal testosterone. Transient elevations in estradiol were seen in 4 of the 35 patients, or 11% with the vaginal ring, and 4 out of the 34 patients with intravaginal testosterone, showing that there was some systemic absorption. And vaginal atrophy, sexual interest, and dysfunction improved for all patients. Now, this study was done with pretty high doses of intravaginal testosterone, and I showed you the estradiol ring is 7.5 micrograms daily. So this just shows the estradiol elevations using the testosterone cream and the vaginal ring, and you can see that in both the vaginal ring arm and the testosterone cream arm, at baseline there were elevations. And it seems like it got better over the course of the study, probably because patients stopped using these hormonal agents or phytoestrogens that they had been using at baseline. But where that line is, that's the line where the postmenopausal estradiol levels are, sort of the 10 to 15. And you see that, quite a few patients have elevations above it. And you see here that there was improvement in sexual satisfaction using both the intravaginal testosterone cream and the vaginal ring. And that's sort of the information from that study. So based on this, we thought maybe we should study Vagifem, 10 micrograms, which would be a different dose, a lower dose of systemic estrogen, since there was some higher levels of absorption with the ring. So in December of 2009, the new formulation of Vagifem was approved with a 10 microgram dose instead of a 25 microgram dose. It was approved to treat atrophic vaginitis in postmenopausal women without breast cancer. And there was actually a black box warning not to use in breast cancer patients. So we tried to perform a study at Sloan Kettering, and we had to really write this informed consent saying this may cause a breast cancer recurrence, and it was a pretty scary informed consent. So it was a little bit hard to recruit patients, but we did. At first, it's administered nightly for 2 weeks, followed by twice weekly maintenance therapy. We enrolled 26 women. At the initial, we stopped the accrual a little early because it was difficult for us to enroll patients with the informed consent that we had. We were hoping initially to enroll 35 patients. But what we did was we gave Vagifem nightly for 2 weeks and then twice per week. We checked estradiol and FSH blood draws also at baseline, week 2, week 7, week 12, week 18, and week 24. And the primary endpoint was change in estradiol level from baseline to week 12. And all patients were either on anastrozole 1 milligram daily or letrozole 2.5 milligrams daily. And the average age of the patient was 55. The majority of the patients were in a relationship or married, and they had stage 1, stage 2, and stage 3 cancer, half on anastrozole, half on letrozole, and half of the patients had been on an AI, aromatase inhibitor, for less than a year, and the other half for more than a year, and the vast majority of them had received adjuvant chemo. So this is the distribution of FSH and estradiol at each time point. And what we see here was there was no statistically significant change in either FSH or estradiol from baseline to week 12, which was the primary endpoint, or from baseline to week 24, which was, the end of the study. However, we did see that there were 6 time points in the estradiol, the red, the yellow, the blues, and the pink, that are elevations above the menopausal range. The red line is the menopausal range. So it's less than was seen with intravaginal testosterone or estrogen, but there was still occasional transient elevations, with there only being 1 sustained elevation from week 18 to 24 in the light blue. And we also showed that there was a statistically significant improvement in sexual function. And again, the steepest change was from baseline to week 12 and continued improvement from weeks 12 to 24. Statistically significant improvement was seen in lubrication, in arousal, in desire, in orgasm, and in satisfaction and pain. So in conclusion, we showed that there was no statistically significant change in estradiol from baseline to week 12, the primary endpoint. Elevations, though, were seen in 5 out of 26 patients at variable time points. The elevations were brief and sporadic. A later peak was not preceded necessarily by an early elevation and vice versa. And the clinical significance of the systemic estradiol absorption is really unknown and just warrants further study and a bigger study. An improvement in sexual function is not associated with an elevation in serum estradiol. So intravaginal 10 microgram Vagifem provided statistically significant improvement in sexual dysfunction in most of the domains, and had no statistically significant change in estradiol. So it was thought to be probably the lowest absorption or best agent at the time. However, more recently, there's a new product called Imvexxy that comes in the 4 microgram, 10 microgram, and 25 microgram doses. And what you see here is that the red, which is the 4 microgram, has no statistically significant systemic absorption compared to placebo. The 10 had slight statistically significant elevation at time point 2 and 4, and the 25 microgram had more. So if you're looking for the product now that has the least systemic absorption, it's Imvexxy 4 micrograms, which we're now going to embark on a study looking at that in our breast cancer patients and seeing what it does in terms of systemic absorption. Because this study was performed in postmenopausal women who were healthy and didn't have breast cancer. And it was also compared here to Vagifem, which is what we did our study with. So when you looked at the red, the Vagifem 10 microgram tablet versus the Imvexxy in the green 4 microgram tablet, you can see that it has a quicker onset, it peaks quicker, and it has, the A is 10 micrograms, 10 to 10. The 10 microgram Imvexxy dose compared to the 10 microgram Vagifem dose. And what you see is that the Imvexxy peaks quicker. It peaks at 2 weeks. It peaks at 2 hours. And by 6 hours, it's down to baseline with a smaller area under the curve of the absorption, compared to the Vagifem, which tends to have peak absorption between 8 to 10, and then has a slower resolution. So we think that Imvexxy 4 micrograms probably has a lower total systemic absorption than Vagifem 10 micrograms, which previously had the lowest systemic absorption. And it's sort of my new go-to medication for patients. It's a little bit different than the Vagifem tablet, which is inserted deep and posteriorly inserted posteriorly with an applicator. This is more anterior, and it has moisturizer along with the estradiol that helps sort of with some of the vulvar symptoms that patients experience as well. So we are looking at, other things that we can potentially use for intravaginal dryness, such as DHEA. And when we think about new drugs, we have to think about other kind of receptors that we pay attention to. So we worry with intravaginal estrogens that it can stimulate the estrogen receptor. But we know that androgen receptors are also relative targets, especially in triple negative breast cancer. We have studies looking at bicalutamide and other androgen receptor blocking agents, and we know that we see triple negative tumors that are androgen receptor positive shrink when we administer these medications. And maybe these drugs work in other breast cancer subtypes as well. We know that about 75% of breast cancers that are estrogen and progesterone receptor positive will also have androgen receptors. 15% of breast cancer patients that are HER2 positive will have androgen receptors, and about 20% of triple negative breast cancers. So given that many of the estrogen receptor positive breast cancers also have androgen receptors, I want to caution anyone in just using DHEA and testosterone and assuming it's safe. So DHEA, it's Intrarosa. It's a vaginal suppository that's FDA approved for the treatment of vulval vaginal atrophy. And it's really used for treatment of moderate to severe pain with intercourse associated with BVA. It's inserted intravaginally once daily at bedtime, and it's been shown in randomized controlled trials to decrease the percentage of parabasal cells, decrease vaginal pH, decrease pain with sensual activity, and improve moderate to severe vaginal dryness. The most common adverse effect is vaginal discharge due to the melting vehicle, and this was reported in the randomized trials at 6%, but I will tell you that I've tried this in patients and that many patients find that it causes way too much vaginal discharge, that they don't like it, that it's too goopy. And I think the number is probably way higher than the 6% reported. And they looked and there was no change in endometrial atrophy after 12 months with the DHEA. There was also a study done in breast cancer patients, not with Intrarosa, but with a compounded vaginal DHEA, where 464 patients were accrued to the study. 147 received non-hormonal moisturizers. 147 received the 3.25 milligram compounded intravaginal DHEA, and 149 received the 6.5 milligrams DHEA, which was quite a large study, and many participants stayed on study. So there was 118 patients evaluable in the moisturizer arm, 117 in the lower DHEA arm, and 110 in the higher one. And what they found was that circulating DHEAS and testosterone levels were significantly increased in patients on vaginal DHEA in a dose-dependent manner compared to moisturizers, so that there was some systemic absorption. Estradiol was significantly increased in those on the 6.5 milligrams per day DHEA, but not in those on the 3.25 milligrams per day DHEA. Biomarkers of bone formation were unchanged in all arms, and maturation of vaginal cells were seen both in the DHEA 3.25 milligrams with 100%, 86% in the 6.5 milligrams per day, and only 64% in the non-hormonal moisturizer. And seeing change in vaginal cells maturation of 64% with non-hormonal moisturizers is on par with what we see. And pH decreased more in the DHEA arms than in the non-hormonal moisturizers, which you would expect. But to remind you, this is a DHEA product, not an estradiol product, and estradiol was still increased when patients were on the highest doses of DHEA, the 6.5 milligrams per day, compared to the 3.25 milligrams per day. So it is something we have to take into consideration. You know, we see it did increase the hormone concentrations, but really further research is needed on the benefits of it and warranted in hormone receptor positive cancers, because surprisingly, there's no black box warning for women with breast cancer, and Intrarosa may be a safer alternative than intravaginal estrogen in breast cancer survivors, but it really needs to be studied because that was not the product that was studied in the Alliance study, and I'm not sure that it's a safer alternative. At this point, the lower dose intravaginal estrogen products are my go-to because I have a better understanding of how they're going to affect and what the systemic absorption is and what we can do for them. And if someone's on tamoxifen, especially when you're blocking estrogen receptors, I'm much less concerned. Now, another area of interest to me is decreased libido. So when women are diagnosed with breast cancer, for many reasons, they often report decreased libido, especially when women are on things like tamoxifen or endocrine therapy. And Phlebanism and bremelanotide are two drugs that are now FDA approved, and they're both approved to treat decreased libido in healthy women. Phlebanism is a 5-HT1A serotonin receptor agonist and a 5-HT2A serotonin receptor antagonist. By blocking both of these pathways, they increases desire. It was Phlebanism 100 milligrams is given nightly in a pill format and compared to placebo in several randomized trials in both pre- and postmenopausal women. It showed an improvement in satisfying sexual events, in overall sexual function, in desire, and in distress. And benefits were seen both in pre- and postmenopausal women, but it's currently FDA approved for hyposexual desire disorder in premenopausal women, and using it and it's premenopausal healthy women. So using it for cancer patients or postmenopausal women is currently off-label. Bremelanotide is a melanocortin 1 and 4 receptor agonist. It activates melanocortin receptors on dopaminergic neurons in hypothalamic center, and it stimulates sexual desire and it stimulates arousal. It's an injection. It's a small sub-Q injection that's administered 45 minutes before intercourse. It has rapid onset and was also shown to significantly improve satisfying sexual events, overall sexual function, and distress. And there's a dose relationship. So the higher doses of bremelanotide showed a bigger improvement in sort of the sexual events and desire. So both of these are products that are being studied in breast cancer patients, and we have an ongoing study now with Norwalk looking at Phlebanism and women who are on tamoxifen or aromatase inhibitors. So let us know if you're interested in the study or participating. So in healthy premenopausal women with hyposexual desire disorder, Phlebanism compared to placebo was found here, and there were multiple studies. So the Violet study, the Daisy study, and the Orchid study all pretty flowers, were shown to have an improvement in overall sexual function based on the FSFI total, seen in the right top corner, an improvement in the distress seen with sexual dysfunction underneath it, and on the bottom corner, it was shown to just improve desire, the FSFI desire. So we showed that it improved overall sexual function, desire, arousal, and decreased distress. So there was an FDA approval for Phlebanism in August of 2015. It was approved for the treatment of hyposexual desire disorder in healthy premenopausal women. And at the time, you had to become a certified prescriber and do a REMS program for it because they thought that there was an interaction between Phlebanism and alcohol. This has subsequently been studied and looked at, and now that black box REMS certification program is no longer there. And it just says, it recommends that you don't take the medicine within 2 hours of drinking alcohol. And if you're drinking a lot of alcohol that night, they recommend holding the medication. Because the FDA initially had wanted them to study it in women who drank alcohol, and they had women come in the day and do shots of alcohol and then take the pill. But when women did, 3 shots of alcohol in the middle of the day and then took the pill, they felt dizzy. Well, I would feel dizzy without taking the pill after that. So it wasn't the best study. And when they further studied it after FDA approval, they realized that warning could come off. So when women are having vaginal dryness and vaginal atrophy and pain with intercourse, really it's important for clinicians and patients to work together to figure out, what is sort of their desires, how much this is impacting them, what is their distress level. And the way I sort of think about it when I'm having a decision-making discussion with people is how important is this to them? And people with earlier stage disease, such as stage DCIS or stage 1 disease, stage 2 disease, or even metastatic patients with limited life expectancy, are more desirable candidates to put on intravaginal estrogens or hormone therapy. Patients with lower grade disease who are node negative, hormone receptor negative cancers, I worry less about. People who are on tamoxifen instead of an aromatase inhibitor, since tamoxifen is going to block your estrogen receptors and prevent this systemic absorption. Patients who have lower risk of recurrence are more favorable, who have a more remote time since their diagnosis. And patients who have severe symptoms that have failed non-hormonal therapies, who are having a distress from this and severe impact, are the patients that are more desirable candidates to start these medications on. Yet, I have patients with stage 3 disease and early metastatic disease who I put on intravaginal estrogens because this is severely impacting their quality of life. So it's really a discussion that patients and clinicians make together. So in conclusion, as you know, sexual dysfunction is prevalent in women with cancer, but we now have more and more treatments for it, and supportive measures include lubricants and moisturizers, physical therapy, vibrators, dilators. Safety of vaginal estrogen is not well studied and unclear in patients with hormone receptor positive cancers. We do await further testing, but if you are going to use it, the best products to use are the lowest estrogen ones, like Imvexi 4 micrograms, or Vagifem 10 micrograms, or Strength 7.5 milligrams. Now, with these products, you may also need to continue using non-hormonal moisturizers. So if you're using the estrogen products twice a week, you may want to use the non-hormonals 2 or 3 times a week also. We know DHEA is effective for treating vulvovaginal atrophy in healthy women and does not have a black box warning, but I'm not sure that it shouldn't. It may need the black box warning, or probably should have it. And decision for treatment, as I was just saying, is a balance between perceived need and concerns of patients. It's a discussion with clinicians and patients. There's no right or wrong answer. And we really need rigorous testing and studies for interventions and randomized controlled trials to better help everyone and all the breast cancer patients, but they're slow to come. But there are many new promising drugs that may be effective for cancer patients. I'm hoping next year we'll have the results from the Phlebanism study, and we're going to start studying maybe bremelanotide, and we're studying Imvexi in outpatients. So there's a lot of exciting studies ongoing, and we really hope to help more and more patients. And we're also trying to do more upfront prevention rather than be reactive. So when we know we're making someone menopausal and putting them on aromatase inhibitors and ovarian suppression, we're starting them on the intravaginal moisturizers. We know that over time they will develop it. At different points, it takes different people a different length of time, but we know if we start patients on these therapies up front, we're probably helping some. And we really want to study the best time to start intervening as well. So I'm going to stop there and thank you all for listening. And if anyone has questions, please put it in the Q&A box, and I'm happy to answer questions for the rest of the time.
Dr. Goldfarb, thank you so much. So much information, but such a valuable topic and so needed. The conversations are always so, stimulating and exciting, and the future is certainly much better than it was, 5 years ago, 10 years ago. So thank you so much. I think you hit the nail on the head, and we probably need to be having these conversations with women when they're starting their tamoxifen or their AIs, because wouldn't that be revolutionary to help these women just kind of ease on into this, decreased circulating estrogen in their bodies. So thank you for that idea too.
Does anyone else have any questions? Were you able to see the slides okay?
I thought it was great. Yeah.
Okay, good.
See if we have a couple of questions come in.
And I can put my contact information in the Q&A if anyone has a question that they want to ask. Oh, actually, my contact information was shared. Look at that.
Great. And also, just to let everybody know that we do have a physical therapist here on staff. Her whole job is pelvic health. So that's really been helpful to some women too. I think you kind of touched upon that. I think so many of the discussions which used to be taboo are now really becoming more and more part of people's conversation. Where do you recommend that women get their dilators?
So pelvic physical therapy is so important. We work really closely with a great team, and there's great pelvic floor PTs throughout the Northeast. So if you're located in Connecticut or New York, New Jersey, there's great people. You can contact me. I can get you in touch with people who focus on this. And dilators are also personal. So we have dilators that we give patients in clinic, but really everyone kind of likes their own set, and you can easily just buy them online.
Great. Just
mail it home. Patients hate walking into stores often and saying, oh, can I buy some dilators or vibrators? So you can now buy everything online. Yeah. We tend to use the Mealy dilators, but there's many different kinds.
Can you talk just for a minute about sort of the whole psychosocial impact with partners and maybe some good suggestions on how to kind of broach the subject with partners?
So some of this happens, I think, when someone's diagnosed with breast cancer, all of a sudden their relationship changes, especially when they're young. It can change where all of a sudden their partner feels like they're the caretaker instead of a partner and an equal. And it often takes a while before it gets back to even playing field where your partner's not looking at you like you're sick or you're different. So I do sometimes think counseling together or doing activities that you used to like in the past to make your, things may not be the same. You have a new norm after breast cancer surgery, your sensation may be different. You may have more vaginal dryness, things may be different. But going back to things you like to do together, making your equals together, whether it's like you like skiing together or going to a movie together. So part of it is going back to things, bringing back things you liked to do in the past, spending time together, and figuring out ways to be intimate, whether it's kissing, hugging, holding hands, cuddling, figuring out ways if you're having pain with intercourse because you're having hip pain, putting a pillow under your hip, or sort of making different solutions to improve the way that you're having intercourse can help. And making sure that you're comfortable, because if you rush into intercourse when you're very dry and having a lot of pain, you're not going to want to do it again, and then you're going to have decreased libido. So one of the things we always say is before we treat decreased libido, we want to make sure that your vaginal dryness is improved, because if you're having decreased libido and your vaginal dryness is not improved, then what we're going to realize is it's really hard to improve your libido with a pill if you're having so much pain, right? So Deb Barden just came out with a study a few weeks ago, it was published. There was a negative study looking at Wellbutrin, which is also thought to treat decreased libido. And one of the reasons I think it was a negative study, it had two reasons. It had a huge placebo effect, but also they didn't treat people's vaginal dryness prior to giving these medications. And I think one of the reasons why our study seems to be a little bit more promising with Phlebanism is we're treating vaginal dryness and giving patients information up front. So if patients know how to treat their vaginal dryness and are using moisturizers and lubricants up front, I think that helps to prepare them for intercourse. Because if you're just telling people, take this medicine to help your libido, and they're having painful intercourse, they're not going to want to do it. It's not going to improve their libido. So vaginal dryness is really key to improve.
Yes. And for our patients that are listening, we do have a marriage and family therapist on our team. Michelle Daly is great. She'll talk with both the patients and their partners to sort of talk about ways and, you know, what else could be going on that could be impacting the relationship. And then, of course, you know, segueing into these conversations is part of Michelle's repertoire also.
I also tell my patients all the time that they have to talk with their partners and be open with their partners, because often patients feel like, I don't want to tell my husband that I have no sensation. He doesn't realize this. But I think a good form of communication with partners is really important. Letting him know, I don't have the same nipple sensation to arouse me that I used to have. I have no sensation in my chest. Or having partners look at the reconstruction. So some of my patients will say, I didn't do reconstruction. My chest is flat. I don't want my partner looking at it. Or I did reconstruction and I don't like how it looks, or I love how it looks, but I don't know if my partner's going to love. So re-engaging your partner, you're going through this with them, have them look at your reconstruction, tell them you don't have sensation or your sensation is different. If you have these discussions, partners are really understanding and can help you sort of the best. So I think involving partners in these decisions and in these processes, maybe seeing a sex therapist or physical therapist together can really help and come up with ways to keep your intimacy alive. And figuring out ways whether, maybe oral sex is an option if you don't want to have penetrative sex or intercourse. So there's all sorts of different things that you can still do.
Well, and I'm just realizing here, we probably should be having these conversations with our reconstruction physicians, our plastic surgeons, to sort of make sure that some of these conversations, at least the doors are open so that patients really know where to go and who to talk to. Because gosh, why not involve these partners? They're coming there to meet the plastic surgeon. Why not sort of go the next step and talk about what could it be like afterwards and maybe some strategies to help with that.
So our plastic surgeons are starting to do this, and they developed a breast cue, which is talking to patients about sort of body image and sensation and pre-surgery and post-surgery. And I think by having patients complete these forms, that it's helping to stimulate conversation. I don't think I said this tonight, but I've said this before to the group, that when I first started as a fellow and I said I wanted to study this, my boss was sort of like, is this even an issue? Like, show me that this is an issue. And I went into the waiting room and just started surveying patients to show them, like, yes, this is an issue. The majority of our patients are complaining of this. And then when I took a job at Sloan and stayed on staff, there's a review of systems form that patients fill out when they're in the waiting room. And I just wanted to ask, like, do you have any sexual concerns, vaginal dryness, hot flashes? It took me about 3 years to get this little box of symptoms added to our review of systems that asks about nausea, vomiting, and diarrhea, that kind of stuff. And now I find it's a great, easy way to sort of start a conversation. I see you've checked off that you're having sexual concerns. What's bothering you, right? Communication is so important in bringing these topics up. And I also tell clinicians that if you don't know what to say or what to do, that's okay. But just sort of normalizing that. I know some people develop sexual dysfunction or have sexual concerns. I see you do. Why don't I get you in touch with a gynecologist or the sexual health program here, or someone who can help you, but just normalizing it and addressing it is important.
Perfect idea.
And I see there's a question asking about studies or benefit for integrative medicine or acupuncture. So we know that Acupuncture is really helpful for menopausal symptoms such as hot flashes. I don't know of any study looking at it to help treat vaginal dryness, but I know a lot of our patients do it for neuropathy, hot flashes, joint aches and pains, and that it's really helped significantly many of our patients.
Completely agree. And our program certainly is going to be up and running soon as COVID lightens up and we get all of our practitioners in line. So that's another really great avenue for patients.
I think that's great.
Well, looks like it's 6:30. Anybody else want to ask another quick question? If there are questions, please contact Dr. Goldfarb personally, or you can reach out to me here at the Breast Center and I can sort of turf you to wherever would be helpful for you. But Dr. Goldfarb, thank you so much. We look forward to meeting with you next year and getting the update from the studies and anything else that comes your way. We look forward to hearing from it. Thank you so much.
It was great seeing you.
Thank
and have
you.
a good night, everyone.
You too. Bye-bye.
Take care. Bye-bye.